recording. Awesome. All right, I'm just going to share my screen. All righty. Okay, well, thank you so much, Dr. Selma Ayerbek, for joining us today and taking the time out to talk to us about the FND specialised clinics. So Dr. Selma Ayerbek completed her medical training and neurology residency in Switzerland. She then completed a 3-year fellowship at the Institute of Psychiatry in London, where she trained in neuroimaging and in cognitive neuropsychiatry. Her main research interests and clinical interests focus on functional neurological disorder. She runs a specialist FND clinic in Switzerland and leads a research program that looks at the neural correlates of the disorder. She's been appointed Professor of Neurology at Bern University, and she's been awarded several prizes for research in her field, and she's on the board of directors of the Functional Neurological Disorder Society. So thank you, Dr. Selma. We're really grateful to have you spend some time with us in our lead up to FND Awareness Day, which is happening on the 25th of March in both Australia and the UK. And I'm delighted that researchers are taking the time to talk to us about their researches and sharing their knowledge. So this paper came out last year in 2020, which Dr. Selma wrote, which is the role of specialist assessment clinics for FND. So this is something that's of significant interest for us in Australia because we really lack specialist clinics in FND. We have a small program for children at Westmead in Sydney, and we're a large country, but we really don't have treatment programs for FND, and we find that many people are slipping through system gaps and struggling to get a diagnosis, and then once they've got a diagnosis, they're not getting treatment that they need. So we're really interested to hear from your research and what you find with your clinics and also the clinic that you run. So you spoke about in the paper that the clinics have an important role in ensuring correct diagnosis and appropriate treatment, and that's obviously something that's really important. We find a lot of people in Australia take a long time to get diagnosed. Some people might get diagnosed within 3 months, but I've heard up to 20 years for people, not getting a diagnosis. So I'm wondering if you can tell us a little bit about what you found in your study when you're looking at these clinics and how the clinics were sort of operating, what they offered, how they help people with FND.
Yeah, sure. Thank you. So you've seen it's a joint paper where we described our 2 different clinics. One I grounded in Switzerland in 2016. Also the clinic of Mark Edwards in London, who is a bit older. He already started this clinic in 2008. And Canada, led by Sarah Lidstone in the group of Tony Lang, had just started a new program. So we thought to a bit put our data together or our first patients and see, do we find similarities and differences? Because we all operate really, the entry to those clinics is through neurology. So first, we really need to establish the diagnosis using not the exclusion process, but rather really all the positive features, positive signs. We ask for additional tests when necessary, and we really take the time to do that. So now I can talk a bit more about the clinic if you'd like, but now back to this paper, we found really commonalities that a lot of patients have a long delay before the diagnosis. What was found that in our clinic in Switzerland, this delay was a bit shorter as compared to others, and it's probably due to the setting. For example, in London, it's really a tertiary clinic where people are referred from all over the country, so the waiting list is pretty long. Whereas in Switzerland, we are based in the University Hospital, where we also have a lot of consultations directly from the emergency room. or the hospital inpatient stay. So that means we would really go as FND specialists to see the patients shortly after they've been admitted for the symptoms. And it's probably one explanation why do we have a little shorter time. And this is extremely important, and this is something we want to develop because we think we can really influence then the prognosis and the outcome by acting early on with an early diagnosis. Then I can go on and make another comment, is that many of these patients also had other symptoms such as chronic fatigue and chronic pain. Yeah. And this is also very important then in triaging patients to treatment, because then it necessitates another type of treatments when there is a lot of comorbid pain, for example, or comorbid chronic fatigue, and there we need a broader multidisciplinary team, not just only psychiatrist, physio, neurologist, etc.
Okay, yeah. And then with the actual programs, what was on offer? So once people were sort of referred to the clinic, what would it look like for them? So what would the sort of program involve?
Exactly. So in our clinic in Switzerland, all the new referrals, we take 1.5 hours of consultation, and they're seen by a junior doctor, supervised mainly by me. Now we have a bit bigger team. And why 1.5 hours? Because it's really just the time to get to the bottom of the history, to collect all the information, because very often these patients already had investigations. So we make a list of all the scans they had, lumbar puncture, other tests, and we really try and gather them all. So usually we don't make the diagnosis at the first consultation. Very often we tell them straight away that we need a second consultation. Mm-hmm. And then we gather all the scans, for example, we look at them. If we need more tests, we'll order them. And then the next consultation, we usually can confirm the diagnosis or not, or refer to other specialists. Because mostly it's the diagnostic process. Often we start already when we are in our differential diagnosis, when FND is already very high in the list, which is often the case because they're referred to us by other specialists. We start already informing about this possibility that it can be FND, and we already start giving some information on that. So we have flyers, written information. We have also short videos in different languages, because in our country we have 3 languages, so that they already start getting familiar with the concept. Mm-hmm. But we don't make a certain diagnosis before we're really sure to have all the informations in hand.
Yeah. Okay. And then once you've confirmed the diagnosis, what then happens after that?
So after that, we take really the time to explain the diagnosis. Often patients come also with their spouse or family members, and it's also important that they hear the explanation. What we see is very often they're extremely relieved to finally have a positive diagnosis, to have a name. And this is something really important also for the family and the partners.
Yeah.
And then we discuss with them really on an individual basis, what would the treatment be? We have, I would say, 2 main tracks. For people who have more motor symptoms, we really favor first referral to physiotherapy. Mm-hmm. For people who have non-epileptic seizures, of course, as when we see the patient, there are no symptoms. The symptoms really come at home. Mm-hmm. We focus then on follow-up by the neurologist, but very often we offer also to see our psychologist who is trained in cognitive behavioral therapy and who will help really follow a calendar or agenda of the episodes. So we ask the patients then to either film and or record when do the seizure happen, what were the thoughts, what did they do, and we really then make a follow-up with them with our psychologist. Then for the physio, for the motor FND patients, we offer physiotherapy at our center with our trained neurophysiotherapist.
Mhm.
But of course, this is not possible for all of them. We are a very small country, but still people who live 2-3 hours away, it's not convenient to come for intensive physio. So there we really try and work in networks. And we hand on also information for the local physiotherapist, or sometimes we also work in tandem. That means our patients would come once a month to our center, to our neurophysio, and then they would go on a weekly basis to their own physiotherapist close to where they live. And then we really favor that the physios talk to each other. We have also occupational therapy. And that also is not for all patients. That would be really on an individual basis who would need more occupational therapy. And then usually they also come to our center, or like with the physio, they would then, our specialist team would communicate with local services.
Yeah, yeah, okay. And what about
so that's for the
yeah,
outpatient.
yeah, what about people who have like sort of the speech disorders? People have problems swallowing, problems with their voice. And also we're seeing quite a few people with functional blindness. What do you do with sort of functional blindness?
Yep, very good question. So we follow them also on the medical point of view. Then specialists, we don't have them affiliated to our FND clinic, but we have then a collaboration with the ENT doctors for speech, and we have their speech therapist. But here I think there is still a lot to develop. I think it's still behind. I would say that physiotherapists, for example, they now are more aware in our country of the disorder. They get, in some part of the country, they get teaching. Whereas for speech therapists and occupational therapy, it's less often that they really are trained to take care specifically of FND clinics. So we have collaborations, but it needs to be developed.
Yeah.
For blindness, also, we don't really have specialists, so we really focus on making the diagnosis and then on following these patients, but we don't really have a therapeutic, clearly defined approach.
Yeah, and that's what I was finding in the literature was, you know, only a handful of papers are on sort of functional blindness, and it's so debilitating. Yeah.
It is, it is. So here we also work a lot with the, for example, informing the family, informing the GP. That would be a lot of part of our work. Because here, for example, the question would be, we don't want these people to have too many external help, because we really want to favor that they really relearn how to live without being always with auxiliary means. And so we really do a lot of information, I would say, of the network around the patient.
Yeah, yeah. And that would also sort of, I imagine, like quite a bit of empowerment around that sort of self-management of symptoms. Do you do work around that? Yeah, yeah.
Yeah, exactly. Exactly.
And with the United Kingdom and Canada program, they were all outpatient as well, or United Kingdom is inpatient, or both?
Yeah, so in Canada, the entry is, I would say, skewed towards functional movement disorder patients, because it was really in the beginning movement disorder clinic, so they see a lot less non-epileptic seizure patients, and they really have this new integrated care where the neurologist, a neuropsychiatrist, and a physiotherapist would really sit together in the room with the patient after the diagnosis was established. And so they had such integrated program.
Yeah, I saw that. Yeah. Do you know if that was helpful, having the neuropsychiatrist and neurologist working together in terms of doing that diagnosis?
Yep, absolutely. They really reported a very good acceptance from patients in this setting, because having them both really sitting in the same room would help lessen this dualism that we see too often. That it is, of course, a physical symptom. It's due to neurological problems, dysfunction in the brain. But very often, psychiatrists are helpful in the treatment and in the management of these patients. So having both specialists sitting together in the same room really provides this message that we work together. It's not that the neurologist would say, oh, you don't have anything, then go across the street and see my colleague over there. It's really to show the integration of both. This is actually also what we do in Switzerland. I was referring earlier that we work together with our psychologist, but we also do a lot of joint session. That means that after a few sessions alone with the psychologist, we would also all sit together and discuss directly with the patient and the family what are the progresses. Is the diagnosis still the same? Do we need extra tests? And we really work together also.
Okay. When you're doing the testing, did you ever sort of come up with, FND and other conditions or things that might have been thought to be FND and then it was something else? Did you see much of that?
That it was actually another diagnosis than FND. Yeah, it happens. Absolutely. Even though patients are referred by neurologists, it also happens that we finally say, no, this is not FND. And then sometimes it's just unexplained, because it also happens actually that the symptoms have no explanation. It just needs follow-up. It doesn't mean it must be FND. Sometimes we follow the patients and it gets better, or we follow the patients and we end up finding another neurological disorder, or it was falsely triaged. Yeah, absolutely.
Yeah. And do you have people that already have a diagnosis of FND present to you sort of just for treatment and management? So they come to you already with a diagnosis, confirmed diagnosis?
Yeah, exactly. So I would say the majority of them already have a suspected FND diagnosis, and in the majority we can confirm it. So I was saying in a few percentage of patients, we actually think, no, this is not FND, this is something else. But the vast majority is actually FND. And this is why our role is also to better explain the diagnosis, confirm it, and start treatment. Because treatment is then not available in other centers. Other neurologists are very good at making the diagnosis, but they don't really have the multidisciplinary treatment that we offer now in Bern.
Yeah, okay. All right. And
the idea, like I was referring also to the network that we're doing with physiotherapists, we also try really to work closely together with other neurologists. When they refer the patients to us, we confirm the diagnosis, but we often send them back to their neurologist that they can follow.
Okay. Yeah, so a bit like that sort of specialist hub and spoke model. So you've got sort of your specialist center, and then you sort of communicate with all your local teams, local providers.
Exactly.
Yeah.
This is very important.
Yeah.
Networks.
Yeah, and that's what I was thinking we need in Australia, because we're a very, very large country, span a large area. Even each state is very large. But we need some sort of specialist centre where we can, because we're never going to reach everyone in rural and remote regional areas in our country. But we really need that sort of specialist centre with all of those outreach where you can get specialist knowledge and you can educate up, local providers. Because our rural...
Yeah, exactly. That's how I see it, even in our small country. And why do we need then specialist centers? Also because we can then provide up-to-date new treatment, and we can make the link with research. And I think this is why we need those specialist centers also to have a dynamic programs of research. And then to really to diffuse the knowledge towards local services, so that it's also more convenient with patients.
Yeah, fantastic. Yeah, no, that's what I think we need here, because some people are operating on very, very old, sort of Freudian theories and not up-to-date knowledge at all. And we've got so many people, if they get a diagnosis, some people are not even given the label. So not only are they sort of don't have a diagnosis explained to them, they will find their diagnosis in their medical records a year or 2 years after it's been made. We have some neurologists that don't even tell a person what the diagnosis actually is, which makes it really hard, because then you can't find appropriate treatment when you don't know what the diagnosis is. Yeah. What sort of
I
outcomes?
agree.
Yeah. So what sort of outcomes do you see? Like, if people go into physio, how much physio do they have in the ideal setting? How long does it go for? And then what happens after that?
So yeah, ideally they would have once to twice a week physio. Our sessions are pretty short. They're only 30 minutes. I would like them to be longer, but this is the entrance system, also the billing system that allows 30 minutes. So ideally it would be at least 1 week, one time per week. And then we usually go for a few months. So let's say then the typical patient who would have a clear diagnosis and then a multidisciplinary setting with both neurology follow-up, physiotherapy and psychology together, they would stay in treatment at least 6 months in our department, where we would also reassess every 1 or 2 months, multidisciplinary, what are the goals. And then if they need more long-term treatment, be it more long-term physio or psychotherapy, we usually refer them to other specialists, because of course in a tertiary specialist clinic we cannot keep long-term patients. We also need a roll-up.
Okay.
So it's really going on a few months.
Yeah. And what sort of outcomes, like when you with that first few months of sort of intensive physio, what sort of outcomes do you generally see?
Yep, we haven't measured that yet now prospectively, so that I can really provide you with a percentage and figures. This is something we'd like to do. But then on the clinical impression, it's very variable, but we have very good experiences with a lot of patients who really clearly, very quickly have an improvement. And for others, well, it takes time. Then we would do our intensive program, like I said, for 4 months, 6 months. And then we refer them to further treatment outside our center, but we always see them then a year later. And then we follow them at least once a year. And we also see that is very good, I think, that sometimes it takes a few years, but we still get there. We still see an improvement.
Okay.
So I think even if we see patients who go quickly a lot better, it doesn't mean the others will never get better. I mean, it might take longer.
Okay. And is that for motor symptoms as well as the functional seizures?
Yeah, that would be for motor. Then for functional seizure, one comment that I could make on the outcome, and I always tell my patients, our focus is not really to become episode free, because it sometimes happens, but in many cases it doesn't happen. But we really focus on the fact that patients then learn how to deal with their episodes or their seizures. Because usually they then start noticing some signs that it might come. They learn how to deal with it, or they deal how to avoid them. And this is already a big success for us.
Yeah. Okay. All right. And did you have any eligibility criteria in order to access your program?
For the outpatient program, no, we take really all referrals where there is at least a suspicion of a neurological problem. We don't accept people where it's written only pain or diffuse symptoms. We really focus on a neurological symptom. Now we are building, right now, actually, we're in the process of opening an inpatient program. And here we will have eligibility criteria that we're defining now. One would be to not have too long-standing this inpatient. We really want people who are quite early still in the process to see if it really makes a difference. And another would be the motivation of the patients and the understanding of the disorder. That means we need to work on that before they come to the hospital, that they've really understood their diagnosis before they really can enter in the intensive program.
Yeah. Yep. And what about age? Like,
and here, of course, we will also exclude patients who have too much comorbid pain or fatigue, because we really want to first see the effect on the neurological symptom. Then maybe in a few years' time we can extend our eligibility criteria, but that would be the first one, because we'll have for now only 4 beds. So we also need to really make sure they benefit the most from our program.
Yeah. And is this an adult program, or do you accept referrals from children?
It's an adult program, but now actually I've been referred quite a lot of teens from or 16, sometimes a bit younger. So we might decide to expand, but our system is made that under 16, they usually go to the children's program and then adults.
Yeah, okay. And do you have like sort of specialized FND children programs in Switzerland?
Sorry?
Are there specialized FND programs for children in Switzerland where you work?
Not that I'm aware of, no. And they're mostly treated in the neuropediatric units, but I'm not aware of a specialist treatment program. There is one hospital in Switzerland that treats general functional symptoms in adolescents, but that would be also gastrointestinal or other functional disorders. And they are starting to get specialized also in FND. So we work closely together.
Yeah, I sort of see there's quite a need for pediatric services, certainly across our country. We've got one specialist clinic, but it doesn't meet the needs of everyone. Yeah.
Okay.
Yeah. Lizzie, did you have any questions that you wanted to ask, especially thinking about, you know, your thoughts around hopefully getting something started?
Yes, a lot of the patients that I probably see, I work for basically a hospital avoidance type role in the community, and we often get patients that have just been through every specialist known to man through various parts of, you know, whether they be gastrointestinal problems or psychiatry, psychologists, and often they've been traumatized through the system, not really feeling as though they're being heard or believed. Do you find that once it's been explained to them the symptoms and the causes of the FND, that you get better outcomes with treatment?
Yeah, absolutely. My experience is that the explanation is essential. And we also very often have patients who report they've been some sort of mistreated in some emergency settings, and the attitude of the staff, be it the medical doctors, the physios, the nurses, would be kind of, oh, he doesn't belong or she doesn't belong here, it's not a real patient. We really feel that very strong. And this is why when they come and see us, they're really relieved most of the time to have a diagnosis.
Yeah. And does that actually impact on their prognosis once the...
Absolutely. It does, makes a huge difference. Because otherwise, especially with this label of psychological, psychogenic, even dissociative, sometimes it's a bit difficult. They really feel that the doctors have missed something because they have a physical symptom. And so when we talk too early about the potential role of a psychiatrist, of a psychologist, patients will kind of think, okay, then it must be the wrong diagnosis. And so this is why we really have to take first the symptoms, the explanation, and then for some patients who would benefit from psychology, we can offer them. And it's clearly not for all of them. We have a lot of patients, and this is actually the case in the United Kingdom. They're not being offered a psychologist or a neuropsychiatrist early on. It's really individually tailored for those patients who express a lot of distress, stress management, emotion. A lot of patients experience also anxiety or depression, and these needs to be addressed, but not because of the physical symptom. And here I think there is often a mix, wrong view that or the older concept of conversion disorder, that the symptoms must be due to a psychology problem, and this is why we refer to psychiatry, and this is wrong. The idea of why we need psychiatrists and psychologists is really for the whole picture, not just as treating the cause.
Yeah, exactly. And for a lot of people, we find they've been through quite a lot of medical trauma in the way that they were treated when they've reached out for care. They've been sent home and completely not able to move, and their parents having to sort of carry them out of emergency. People that weren't able to swallow for a week, and almost on death's door, so not able to swallow water. So there's been a lot of people have expressed quite traumatic experiences when they've reached out for care. And we ran a pilot counselling program last year, and we're running it again this year. And we found that we had to undo a lot of the medical trauma, and that sort of helping people to feel validated and that their condition is real, because people came with so much medical trauma before you could even get to sort of starting to treat, the actual condition. So,
we've seen that a lot here in Switzerland as well.
Is there a, with the research aspect, obviously, it's the explanation of the diagnosis in a simple way being a software problem. I think I've read recently that there are different types of neuroimaging that are showing differences in, it might have been in your article, but basically saying that there are differences if you look at the amygdala or the emotion and the movement and the emotional center very closely intertwined. So is there anything new on that area, differences in the physiology that might explain why some people are more prone to get FND type issues?
Yeah, exactly. We're running now a research program, and like you say, the explanation we try and give our patients is this software hardware issue, and that we're trying to understand why the software would go wrong. And here, one of our line of research is focused on the influence of stress and emotion management. And I think this is really important to bring together again neurology and psychiatry, because we've discussed now how difficult it might be for patients to understand why would they want to refer to me to a psychiatrist. I'm not crazy. And this is something that I really also kind of want to emphasize, that it doesn't mean it's for craziness. It means that the brain is our organ where we store our movements, programs, our everything that needs to move and talk and see, but it also stores our emotions, our memories, and that it needs to be integrated. So it doesn't have to be neuro or psychiatric. And so this is also reflected in the work we're doing in our research team. We're trying to see what are the mechanisms of motor control. We have some studies, MRI, where our participants do some tasks, motor tasks, and we look at what brain areas are involved, and in particular what we call the sense of agency, so the sense of being the agent of the movements, for example. And then we are now looking at the influence of stress. So we are also measuring some biological measures of stress, the cortisol in the saliva, for example. And we want to see if that can influence the brain mechanisms. So we kind of also would like to put together how far does stress and emotion impact these physical brain mechanisms. And if so, if we find something, how could we influence that? And we have now currently an open study which tested the effect of mindfulness stress reduction therapy, again, to see the brain mechanisms. So it's not a clinical study yet. The outcome measure is not really to see, do we improve the symptoms? It's really still in the research area where we want to see, does stress reduction really influence the biological measure and the brain software mechanisms? Really first trying to understand the mechanisms of the influence of stress.
Yeah, and I think a lot of people would relate to having worse symptoms at times that they're stressed. Sort of like, you know, other people can have a stress response or have an emotional response to something and not become paralyzed. But some people with FND, they get emotional, they get stressed for whatever reason, and they do develop symptoms. I think
exactly. For some patients, it's pretty clear, the link with stress. And interestingly, for others, they would, on the contrary, report to say, well, I had a terrible period in my life, etc. But right now, I'm pretty good. I'm in a good place. And now I have my symptoms. So how is it related to stress? So, and I think this is where we need more research, because we don't really know the exact role of stress. What we know is that the cause is not direct. So we should really stop calling this disorder psychogenic by meaning, okay, a psychological stressor must be the cause. This is wrong. But we really need to better understand the role of stress, of chronic stress. How does it work? We are also looking, and there is also a group in the US, the group of Mark Hallett, who's looking at potential genetic and epigenetic changes. We are trying to see if there are maybe some vulnerability factors that could make this particular person more at risk to develop FND later in life.
I was actually going to, that led me on to my next question would be, is there any genetic basis? Some people being, excuse me.
Was that your paper that we looked at? There is a paper that came out last year. I think it might have been your paper with the genetics and the gene combinations that were more susceptible to childhood trauma if you had a certain gene combination.
The link with childhood trauma is not well established yet. What we found in our small pilot study that we've done is we looked at one gene, the oxytocin gene. The oxytocin is a very important hormone for bonding between a mother and a child, but also in the stress cascade. And we saw that there are some changes, epigenetic, so that means they come later in life, those changes, but they can influence the way the certain proteins involved in this oxytocin transmission is regulated. And we saw a difference in a group of patients with FND as compared to a group of healthy controls. So it suggests that maybe there is a signal that some genes are modified in FND patients. This other paper from Mark Hallett looked at a bigger panel of epigenomes, and they also found some a signal, I would say, that some might be altered and in relation to then changes in the brain. So it's really an early phase of research in this area. So we really cannot make any conclusion yet, but it's really a research that we need to develop. Now, we don't have evidence that there is a clear genetic basis, like a mother or a father would transmit the disorder. We don't have any evidence for that. So it's not, in that sense, a heritable disorder.
Okay. So it would be more like some gene combinations could make you more at risk or more vulnerable. So genetic vulnerability.
Exactly, and one direction would be really to try and look at what we call the gene environment interaction. Because the idea would be that you're born with certain genes that put you at risk, but if you don't have the triggers in your life, then you even with this genetic material, you will not develop the disorder. And it would be really the combination of having this particular gene set plus some stressors or other things that we still need to discover that would lead to having FND.
Thank you.
Very interesting.
It's
Yeah, you've got some,
really,
wonderful research happening now. It's really good to sort of hear all this research. Yeah. Lizzie, did you have any other questions?
I was going to ask about coaching and obviously psychology. If there is a need in certain people to have psychology, but I'm just thinking about coaching. You know, I do a lot of health coaching with my patients and actually helping them, because I do believe there's a link between your psychology and your physiology, and they're intertwined. And so if you can actually work with someone to assist them to change their mindset about the way their body is misbehaving, then they've got more control, and as you say, they've got more agency over their symptoms, and that would actually help their treatment program.
Yeah, absolutely. We don't have programs involving coaches, but I think it would be a very nice idea. Also, it could help reach patients who, even though they've been given an explanation, they're still very skeptical about it.
Yeah.
And then sometimes we see also patients who come to therapy, but they really come very passive. They don't believe it will help, but they kind of do what the doctors has told to do. And here, I guess some coaching would help in making them really understand why would that be important? Why do you engage? Why do you want to do that or not do it? And that would probably be very helpful in this multidisciplinary network to be an add-on with the GP, with all other specialists. The coach could be, because I would imagine also the coach might go to the homes of the patients.
Yes,
too. So this link also with putting together what are you capable of doing at home and with the medical world would be a nice link.
Yeah, also it might be might open up options for people who have got the stigma about seeing a psychologist or a psychiatrist. It's about helping them improve on what they've got rather than treating a problem which they might not agree that they have.
Yeah, absolutely. Yeah, there could be a more neutral way to approach them.
Yeah.
Without this label of psychology that sometimes is really hard to accept.
Yeah. No, I think, do you have an exercise physiologist on part of your multidisciplinary team at the clinic? I just know with the fatigue factor being problematic, sometimes an exercise program is sometimes hard to be tailored to your, the individual patients because of their fatigue levels, but they still need to increase their exercise routine.
For that, so the setting we have in Bern is actually ideal for that, because we work closely with the psychosomatic unit, how it's called, where they actually treat other types of functional disorders, in particular chronic fatigue syndrome. And so the team of physio there is really trained also for that, for chronic pain and chronic fatigue. So they would, exactly. They have walking programs, for example, or group sports activities, group swimming pool activities, where people can really also at their rhythm join these programs.
Okay,
so,
thank you. I think I've exhausted all of my questions, but thank you so much. Really appreciate it.
Yeah, and thank you so much for your time and sharing, your expertise and your knowledge. And
well, thank you very much for
doing.
taking the time for such a
and thanks for the research that you're doing. You've got some really great projects happening. Yeah, cool.
Okay.
All right, well, thanks so much.
And thanks for the work you're doing, because we need networks really everywhere in every country, but worldwide. To disseminate the knowledge and know-how.
Oh. All right, we'll be in touch. Okay, thanks so much.
Thank you. Thank you.
Thank you.
Bye.